Hey everyone, and welcome back for part 7, the final part of our EKG Basics series. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator for PHI over in California. And today we're going to be talking about accessory pathways. And really, we're going to be talking about tachyarrhythmias and the different ways to approach them. I think that one of the biggest injustices that the American Heart Association has done for pre-hospital EMS is that they definitely treat to the greatest common denominator, and they don't take specialized clinicians into account, which is what each and every single one of you are. So we're going to dive a little deeper into these tachyarrhythmias and looking at these different accessory pathways and hopefully help to clarify some of the things in your mind. So we're going to review WPW, which is the most common accessory pathway that we see in humans. We're going to look at the difference between an accessory pathway and just a regular PSVT. We're going to review Afib with RVR as well as Afib with WPW, and we're going to look at different mechanisms of action for various antiarrhythmics that we carry on our aircrafts. So first things first, what is WPW? So it is a what we call a pre-excitation syndrome that allows for bypass of the AV node. So it's typically through a small accessory pathway on the off of the right ventricle, sometimes off of the left ventricle through something called the bundle of Kent. You can typically have about one accessory pathway, but as many as 8 have been documented, and it's present in up to about 3% of the population, much more common in women than it is in men. So what are we looking for when we're looking for WPW? So we're looking for that wide-ish QRS. So we're looking for a QRS that's not as wide as like a left bundle branch block, but we're definitely looking for a QRS complex that's wider than normal. We're also looking for that delta wave, which is that slurring up of that QRS complex. But the absolute most important finding that you are going to look for is they have a short PR interval. Remember that every single time you look at an EKG, you need to look at the PR interval. If it's between 0.12 to 0.2 seconds, then that is normal. If it's shorter than 0.12 seconds, you probably have an accessory pathway. If it's longer than 0.2 seconds, then you have some sort of block, right? You have a sick AV node, but a short PR interval has to be present because that is really what tells me that somebody has an accessory pathway. So looking at this EKG right here, we see, looking at specifically like lead V2, which is probably the easiest lead to look at. So we have that pretty short PR interval, right? There's definitely not 3 little boxes between that P wave and the beginning of the QRS complex. As soon as the P wave is done, we start kind of slurring upward toward the QRS complex. So we have that really short PR interval. The QRS complexes are not necessarily wide, but they're definitely a little wider than a normal QRS complex. And we can see that they absolutely start with that big slurring up, that big delta wave at the beginning of the QRS. And then the QRS kind of becomes narrow as the ventricles kind of catch up with the depolarization there. So we start with that big slurring upstroke right there, and then the QRS kind of catches up, and that is what we refer to as our delta wave. So what exactly is it? So the SA node fires and sends its signal out to the atria and down to the AV node. Well, that signal travels through the accessory pathway first. But the problem is that, remember, if you're not going through the AV node, then you're not using the freeway, right? So you are having to use the surface streets. So if you conduct a beat through the accessory pathway, you are going to have to use the surface streets, meaning that every cardiac cell has to depolarize the next cardiac cell. So it takes forever, which is why we see that delta wave. So we see that really what is going to be a very wide QRS as we go from cell to cell to cell to cell, and we depolarize very, very, very slow. But after about another 0.08 seconds or so, the AV node conducts the rest of that signal down through the His-Purkinje system, and the ventricles catch up, and so the QRS then finishes pretty narrow. So it starts off wide as that portion of the heart where the accessory pathway is starts to beat, doing this cell-to-cell conduction, and then the AV node gives the rest of the heart the signal very quickly, and the QRS catches up, which is why we have that delta wave. So pretty important to understand that concept. So when it comes to WPW with an SVC or an SVT, the accessory pathway is what causes that circus movement. So that that circus movement that causes the SVT. There's two types of SVT with WPW. There's orthodromic SVT and there's antidromic. It doesn't really matter that you know these. I'm only explaining this to be able to transition over to the difference between SVT with WPW and Afib with WPW. But you've been treating orthodromic and antidromic SVTs correctly your entire career. So first we're going to look at this orthodromic on the left side of your screen here, and we see that the conduction is going down through the pathway, right? So the beat goes to the AV node, and then the AV node transmits it through the bundle of His, and then the left and right bundle branches, and down to the Purkinje fibers. And so it's going through the normal highway of the heart, the normal pathway of the heart, and then it travels back up through the accessory pathway and right back to the AV node. So we have this rapid circus motion, and all we have to do is break the circuit. So this, because it's going through the normal conduction of the heart, would be a narrow complex tachycardia on the EKG, because it's traveling through the normal highway and then it's just coming back up through the accessory pathway. We would normally treat this regular narrow complex tachycardia with some sort of AV nodal blocker, and so we would maybe do some vagal maneuvers and then give adenosine. Adenosine is going to cut conduction to the AV node and is going to break that circuit and stop that tachycardia from happening. On the right side of your screen, if you have this antidromic SVT with WPW, then we have this accessory pathway that is conducting this really slow ventricular contraction. So the QRS is super wide, and then the electrical signal is actually traveling back up through the His-Purkinje system, back up to the AV node, and then the AV node is conducting it back out to the accessory pathway. And so you end up with this really slow, wide ventricular tachycardia, or what looks like a ventricular tachycardia, because the accessory pathway, remember, is like the surface street. So it takes forever for each cell to go from cell to cell to cell to cell. So you end up with this regular wide complex tachycardia. So there's two things that we can give to stop this from happening. We can give a nodal blocker. We can give something that slows conduction through accessory pathways. We could give a calcium channel blocker, and all of these are going to help, which is what we've been doing in the past. We can cut the circuit in either one of those, so we're going to give things like amiodarone or procainamide in order to stop that from happening. So you've already been treating these two correctly your entire career, but really what we're going to talk about now is going to be Afib. So remember that in order to treat regular narrow complex tachycardia with normal vagal maneuvers, adenosine, etc., treat regular wide complex tachycardia with amiodarone or procainamide, and if they're very hemodynamically unstable, or you're not sure what you're looking at, and you're in doubt as to whether it is narrow or wide and they're hemodynamically unstable, then you just need to shock them and do a synchronized cardioversion. All you need to do is break that circuit and they will be reset. But let's talk about the dangerous one, WPW with Afib. So this can occur in as many as 20% of WPW cases. And the biggest concept is that we really don't want to be knocking out the AV node. So the AV node acts like a brake for the ventricles. Most of us know that each node has an inherent rate, right? So we look at the SA node. The SA node's inherent automaticity rate is 60 to 100 beats per minute. If the SA node died and the AV node had to take over, the AV node has a rate of 40 to 60, and then we have the bundle branches and the Purkinje fibers, which are anywhere from 15 to 30 beats per minute, and so on and so forth. So we have this low number for each one of the nodes, but most people don't know that all of the nodes actually also have a top number. They have the most amount of beats that can be conducted through them in a given minute. And the AV node is about 180 beats per minute, give or take. And by give or take, I mean give or take about 20 to 30 beats per minute. But that's a pretty important thing to realize, that if you have ever treated somebody who is in SVT, which I'm sure almost every single person listening to this has, that you've probably never seen a regular SVT greater than about 210 to 220 beats per minute. And I wouldn't say probably, I would actually say you definitely have not. And if you have seen something faster than 220 beats per minute, then it was not SVT with WPW. It was Afib with WPW. So this is a very important thing, that if you simply look at the cardiac monitor and you see that the heart rate is bouncing between 250 to 300 beats per minute, that is immediately not an SVT. That is an Afib with WPW, and we need to be treating it differently. So do not knock out the AV node when you have Afib with WPW. So let's take the time to truly grasp the EKG findings of Afib with WPW. So the first is that it has to be irregularly irregular. We know that from basic dysrhythmias course, that anything that is irregularly irregular has to be Afib or VFib. The QRS complexes will be wide when you have Afib with WPW, and that's because you have so many beats that are being conducted through the accessory pathway. And remember that anything that gets conducted down through that accessory pathway, just like when we saw that antidromic example in a few slides ago, that it's going to be wide, because if it conducts through the accessory pathway, then it's going to have to go from cell to cell to cell to cell, and it's going to be a wide QRS. The morphology of the QRSs are changing. So we look at the EKG, and some of the QRSs are wide, some of them are narrow, some are tall, some are short. The morphology of the QRS complexes is changing, and that's because some of them are coming through the accessory pathway, and some of them are being conducted down through the AV node and the normal pathway. And then 4, and this is the most important part, is that from beat to beat, and not everywhere, but just in several places on the 12 lead, you will see that the ventricular rate is nearing 300 beats per minute, meaning that there are 2 QRS complexes that are only one big box away from each other. And let's talk about why. So with normal Afib conduction, the atrial rate is anywhere from 300 to 600 beats per minute. The ventricular rate, though, when you have normal Afib with RVR, is anywhere from about 150 to 180. And that's because if it's just Afib with RVR and there's no accessory pathway, there's no WPW, then every beat has to be conducted through the AV node. There's nowhere else, there's no accessory pathway for it to go. So even though the atria is conducting about 300 to 600 beats per minute down through the AV node, the AV node is killing hundreds of those beats because it can only transmit about 180 beats per minute down to the ventricles. So if you see a rapid Afib at a rate of 180, it would actually be safe to give nodal blockers to these people, even though we've been taught our entire careers that if you give a nodal blocker to an Afib patient, they will die. We know that that is absolutely not true, because probably everybody listening to this has misdiagnosed somebody with rapid Afib as just an SVT at 180, and then they gave adenosine, and they saw that it in fact was an Afib, and then the patient came right back to life and had Afib still. And so it is very safe to give give a nodal blocker for rapid AFib. It is not the normal practice, but it would not kill your patient because all you're doing is stopping conduction to the AV node temporarily, but there's nowhere else for those atrial conductions to go, right? Because they don't have an accessory pathway to get around. So when you have WPW, however, you don't have the ability to only have that one pathway. So when you have AFib with WPW, you have tons and tons of QRS complexes that are being conducted down through the AV node, upwards of 150 to 180 beats per minute, and those are all narrow. Many of those are being killed by the AV node as well, so the AV node is not conducting hundreds of beats that it's receiving from the atria. However, the accessory pathway will conduct anything that it receives. So the accessory pathway is going to be conducting as much as it possibly can, upwards of 100 to 150 beats per minute. And those are going to be really wide because you have this cell to cell to cell conduction, and it's going to be a really wide complex. And so when you're looking at this 12 lead right here, we see that this is a rapid rhythm. And this is a great example of an AFib because we kind of can see all four criteria right in front of us. So we see that it is absolutely irregularly irregular. One of the big keys that we look at is we need to pick 2 to 3 leads to look at, and just look at the amplitudes of all of the QRS complexes. If the amplitude of the QRS complexes are changing, then more than likely it's an AFib. So we see that this is irregularly irregular. We see that there are many QRS complexes that are very wide, and we see some that are pretty narrow. We also, up at the top right-hand corner right there, we can see 3 different beats that all look very different from each other. So we have a changing morphology, as some of those were conducted through the AV node. One of them is probably a fusion beat because it starts off really wide and finishes narrow. But the morphology is changing, and then you can absolutely see that circle on the bottom that we have those 2 QRS complexes that are only about 1 big box away from each other. So that ventricular rate is nearing 300 beats per minute. So this is AFib with WPW. This is not a AFib RVR, right? AFib RVR cannot exceed a heart rate of about 180 to 200 beats per minute. And if you are seeing this ventricular rate reaching almost 300 beats per minute, this has to be an accessory pathway. And if you treat it with calcium channel blockers and nodal blockers like digoxin, like diltiazem, then this could be very, very bad for this patient because you're going to knock out that AV node, you're going to knock out the brake, and you're going to allow all 600 beats per minute from the atria to be conducted down through the accessory pathway. So this one, again, you can see that it is a very fast, irregular rhythm. If you look at 2 to 3 different leads, you can see that we have big changing amplitudes of our QRSs. So this is absolutely some sort of AFib that we're looking at. It's irregularly irregular. We see that there are many QRS complexes that are very wide. We see that morphologies are very obviously changing from beat to beat, and we can see that we have ventricular rates that are nearing 300 beats per minute on several of these QRSs. So this is AFib with WPW. So if these patients are given nodal blockers, you can absolutely send them into VFib. Remember that the AV node is a brake for these patients. The AV node is killing hundreds and hundreds of these conductions of these signals that are coming from the atria. But as soon as you take that brake away, all 300 to 600 beats per minute coming from the atria are now going to be conducted right down through that accessory pathway, and we are going to place our patient into VFib. So make sure that we are noticing this patient, AFib WPW. Remember that with rapid AFib, 1 out of 5 of your rapid AFib patients is going to have this WPW. And so we need to recognize these patients and not give them the nodal blockers and calcium channel blockers that we would normally give. So how do we treat them in the field? So the first thing we look at is amiodarone. So amiodarone is a class 3 antiarrhythmic. So we've got that sodium channel blocking um, going on, but it's also a class 1, class 2, and class 4. So it does have beta blocking and calcium channel blocking properties as well. So it can potentially be dangerous for WPW. That is what we have in the field, and so that is going to probably be the only thing that you're going to be able to use. Remember that you can also break the circuit with electricity, but the best possible thing that you could use is going to be procainamide. Procainamide is made for this disease. It's going to slow that ventricular conduction. It's going to reduce conduction through the accessory pathway. This is really what procainamide is made for. If in doubt, you can always shock. We in California, we do not carry procainamide on the aircraft. I'm not sure if your program does or not, but procainamide is definitely going to be the preferred treatment for Afib with WPW. So takeaway points. Afib with RVR, we're going to have ventricular rates of 150 to 180, no changes in morphology. It's going to be safe to give those beta blockers and calcium channel blockers. Afib with WPW, we're going to have a wide QRS, changing morphology, and we're going to have those ventricular rates nearing 300 beats per minute. The preferred treatment is procainamide. You can also use amiodarone, and if in doubt, you're going to shock your patient. If you have any questions or want to leave any comments about this presentation, feel free to reach out to me, guys, at akaiser@phiairmedical.com, and we will see you out in the field.